So, welcome to this episode of Getting to Zero, which is a series of conversations with experts to really reflect on how do we put a complete stop to vaccine preventable deaths and get them to zero. Today, I'm delighted that we have with us Dr. Anant Bhan, who's a very eminent researcher and an expert in global health, health policy, bioethics, mental health. He's also a mentor and a key researcher at Sangath, India, a leading and a highly respected health research organization co-founded by Dr. Vikram Patel, who's just been nominated as the chair of global health at Harvard Medical School. And so welcome, Dr. Anant. We are privileged to have you with us today. And I must tell the viewers that I got to know you after joining Sabin, and I really have developed so much of respect for you because the kind of work that you have led has actually given me new and refreshing insights, reminding all of us that learning never stops. It's a continuous process and an endless pursuit. So thank you for joining us.
Sure. Thanks, Anuradha, and a pleasure and honor to be here today and to be speaking to you, and thank you also to colleagues at Sabin for organizing. So as you mentioned, Sangat, which is where I'm affiliated with, is an organization which has been working for the last more than almost 2 decades. We were set up in 1996 in Goa in Western India, but now we work across multiple states in India. I'm based in Central India in Bhopal. Sangat has been working for many years in mental health, and mental health by itself, because there is so much stigma and discrimination against mental illnesses, there is already a fair bit of marginalizations for persons with mental illnesses. And in Sangat, we have learned a lot from that and tried to find ways of working with communities, with health systems to ensure that we are able to address the huge treatment gap which exists. Now, a lot of learning from that has also informed the work for which we are again funded by Sabin and other institutions within the Institute for Health Equity, Advocacy and Research, IHER. IHER was started a couple of years ago, actually during the pandemic, where we were informed by prior experiences of some of our collaborators who are medical doctors, health professionals, educators, but are also persons who come or identify with a form of marginalized identity. So Dr. Satendra Singh, who's a person with disability, he has polio, and he's a physiology professor. Dr. Aksar Sheikh, who's a trans woman herself, a community medicine expert. Both of them spoke about some of the challenges which exist for trans people, so persons from transgender communities and persons with disability. And we discussed about the fact that there is a need to do more concerted efforts. And what Sangat could bring to the table at that point of time was a history of doing high quality evidence-based research, the ability to host an initiative and to be able to work with our collaborators to do projects which would hopefully bring about meaningful evidence generation, but more importantly, ensure that it is done in a respectful manner, working with communities, and try to take that to policy advocacy and change. So we started off with a few projects which focused on trying to understand the challenges specifically during COVID-19, and informed by that, also realized as the vaccine started coming in during the pandemic that there was a need to look at access issues, especially for these marginalized communities, for COVID-19 vaccination. And that is the project for which we were funded by Sabin through the VAD initiative. And that was a very useful exercise. As you were rightly saying in your introduction, there is a lot of learning which is there in global health. And for me personally and many of my other colleagues, this has been a process of a lot of learning. And the reason for that is that, I remember one of the first meetings we had with community members, And we asked them, we are here, we want to do work with you, we want to understand what are the kind of things which are challenges for you from a health perspective. And there was a very thoughtful response, which was also a challenge to us. They said, people like you, who are researchers, who are not from the community, have been coming to us for 20, 30 years. You ask us the same questions, you take that and you have career enhancement, you might get big grants, you go and speak in fancy conferences. So you get something out of it. What do we get out of it? Nothing has changed for us in 3 decades. So what are you going to do differently? Why should we share our trauma with you, our lived experience with you? And that I think also made us reflect with our collaborators on how could we do things differently. And one of the things we've done differently, especially in iHear, is co-produce knowledge with communities. And what that really entails is actually a lot of work which even informs what kind of questions we want to ask, what kind of research do we want to do, and how do we do it, right? So our teams are largely comprising of individuals who are from the communities. In fact, within our team, we have made a decision that we will not do a research project with a particular community unless we have representation within the team from that community, because otherwise we don't feel we have actually the internal inherent knowledge to be able to do research with those communities. We do a lot of prior discussions, we do a lot of outside engagement with multiple community members. There is a lot of diversity within communities as well, and we have to recognize that there is intersectionality, there are language challenges, including just in a country like India, which is so diverse and large. So we have tried to consciously take that approach, and that I think has been helpful for us because we are trying to approach this in a way where Sangat is sort of the host of the platform, but Sangat is not iHear. iHear is much beyond. It's a larger idea where we are trying to coalesce a lot of collaborations and work with community members. And that has helped us, I think, in many ways in coming up with evidence which I think presents a unique perspective on some of the challenges. So in our vaccine equity project, which looked at COVID-19 vaccine access, we have found out that as much as there was a positive intent by the health system in trying to reach out to communities, because of course they also wanted more vaccine coverage to happen, the larger systemic inequities which exist with regards to these communities sometimes are a block, sometimes are an impediment for these communities to be able to access vaccines.
So thank you for that. And actually, I was so proud when I joined Sabin of the work that has happened in collaboration with Sangat, and the fact that Sabin actually could really think of a shining spotlight on some of these blind spots, frankly, within the health system and also within the psyche of the policymakers and the program managers. So I really want to sort of get into this in a bit of detail and ask you as to what is your experience now when you have started to take a much more participatory approach, where you are not just designing your research in close collaboration with communities, but you're actually very proactively inducting members from the marginalized communities into your teams, right, into your research teams. And I was highly struck by the fact that even at this conference, your presentation team actually has two people, one transgender individual and another completely visually impaired. And I think that makes all the difference. So is that something which you have found easy, or have you also faced some obstacles or challenges as you moved along this direction?
No, thanks, Anuradha. That's a great question, and you're right. There's been a lot of internal thinking about some of these approaches, and I see actually a lot of positive from a learning perspective. When we were thinking about how to conduct these research studies, which are important research studies, it's then also a question of the process involved. Of course, you need to develop the tools. You need to understand that how will we do the data collection, how will we do the analysis, how will we report, but more importantly, who will do the research is an important part of it, because unless people are comfortable sharing, they are likely going to come back and say, this is just a group of, let's say, cishet able-bodied individuals who've been asking us these questions. They will, probably benefit from this, but there's nothing in it for the communities. And that's a legitimate question for them to ask. And that's also true of an organization like Sangat. Sangat is well known as perhaps one of the more experienced research organizations. So there's likely that in some smaller community groups, there'll be skepticism. Why is an organization like Sangat getting into this space? Shouldn't this be driven, let's say, by communities or community-based organizations? And hence, our conversations with our collaborators, with advisory board members, as we slowly started expanding the nature of our work, focused on some of these issues. And I think one of the best ways to address that is to try to figure out mechanisms. When we say we want to do co-production of knowledge, should it just be touch points like let's say let's set up a community advisory board, or let's do a couple of workshops in the communities, and that's then tick on your on your application forms to the IRBs or to your funders and said, yes, we've done community engagement. And that is, of course, an important part of any good quality community engagement exercise, but is not enough when your entire project is actually based on working with marginalized communities. So we did have to look out and ask around and in our recruitment, be very clear that we were going to prioritize recruitment for individuals from marginalized backgrounds, and sometimes applications would trickle in, but they would not be people we thought were the right pick for joining the projects. But over time, we've gotten some really good applications, some great colleagues who've joined, who are actually great at the science, the research aspect, the sensitivity and of the approach which is needed, and have helped us in many ways in learning as well, because they bring lived experience to the research that they conduct. And again, reflecting on mental health, which is what Sangat does a lot of now globally within mental health as well, lived experience is considered an important form of expertise. In fact, funders like Wellcome Trust now expect you to have persons with lived experience as collaborators, as co-investigators, and that's a requirement. You cannot put in a funding application without that in some of the grants that they fund. And that, I think, recognizes that we have to look at that as a form of expertise as well. It's not just getting advice or treating them as a resource, but actually involving them in all aspects of the research.
So you bring up a very important issue, and that is whether the research should be for the community or should it be with the community. So my question to you is, so we are looking at research and then we want action, right? But between research and action, is there another vital step which is really advocacy, right, by communities themselves?
Sure.
About their own rights, that is then going to enhance pressure on the policymakers to respond, right, to the felt needs of the community, which research is only helping surface and crystallize.
Absolutely, and I think for researchers and for folks in health systems, it's important to recognize that this is, of course, a specialty by itself, right? How to do advocacy right, what are the kind of touch points you should be identifying, who are the right people to reach out to. There are great people in policy circles as well, people who are sensitive, who get it if they are given the right information. So over time, what we've tried to do, for example, is in our dissemination meetings, we call policymakers, but we also call community members. And when community members speak to their lived experiences, it's a very powerful narrative. You cannot negate someone's lived experience of having been traumatized or having been discriminated against. There are legitimate questions of someone like me who's clearly in a vulnerable health situation. Why is it that I was not in your priority list of vaccination? I clearly should have been. Or I went to a vaccination center and I was disrespected, and hence I did not access vaccination. That your website, which allows for us to access vaccination, doesn't have the ability to cater to the needs of individuals like me. And I think that becomes a very compelling argument for the policymaker to see that, yes, there is a problem and we need to fix it. What's also important there is to leverage advantages you might have, for example, from a law perspective. In India, we have a very progressive Mental Health Care Act. We have a Representation of Persons with Disabilities Act. We have a Transgender Care and Protection Act as well. And since these are legal mandates, policymakers have to, of course, respond to any violations which exist within that. And these are good frameworks to refer back to, because then it's not, they cannot dismiss that, right? It's a legal requirement under the Indian Constitution to respond to those needs. And I think it's more a challenge sometimes to bring them to the table. Once you get them to the table, I think it's easier to communicate some of these findings. And some of that leads to small changes. For example, I remember a meeting we had with the National Human Rights Commission in India. So we went there, spoke about our work, and they said, what is the kind of things you want to change? And send us a complaint, because then we can take that on file and bring about change. So, very quickly within Delhi, all of the metro station washrooms were made transgender inclusive by just changing the washrooms which exist for persons with disability to also be washrooms which persons who are from the transgender community could. So these are small wins, but you could also do major changes by working with policymakers who are sensitive. So we've seen a lot of sensitivity. We have seen some policy impact, but I think it's just this continuous dialogue and finding mechanisms of communicating with key policymakers which makes a difference. Over time, we hope that this is something which comes, it should become normal for policymakers to think of needs of marginalized communities and use that to inform design. And that would be the true transformation of the health system as we would expect it.
Absolutely. So rather than marginalization, you have mainstreaming of these considerations, so that sometimes a perceived adversarial position is absolutely obviated, right? And and the design itself becomes very sensitive to the needs of these groups which have historically suffered from a lot of neglect and exclusion. So let's just change the tack a little bit, Dr. Bhan. And I have been thinking about your work with young people, because particularly on mental health dimension. And in my understanding, you have engaged with the youth a lot, and also exploited digital platforms. Do you think that on HPV vaccine introduction and scale up, we have an opportunity to engage with adolescents and young men and women and really harness their potential? Because HPV is now an area that we know is lagging. HPV vaccination is an area that is lagging, and it does require a special effort. So at Sabin, we have launched a Global HPV Consortium, where we really want to do our very best and bring all our partners together to work with countries and support them in improving the coverage of HPV vaccination. And one of the very important prongs of our strategy is to actually begin to understand the potential that exists, to use the power of adolescents and young people, because we are also increasingly hearing from adolescents, like in case of marginalized communities, nothing about us without us, right? So would you share some of your experiences, with us, and just sort of share with our viewers what are some of the steps that can be taken in order to engage with adolescents and young people with regard to HPV vaccination and other future vaccines as we go along?
Sure. No, absolutely, you're right. So Sangat with partners has been doing a lot of work with young people, especially around areas of mental health, school mental health, adolescent mental health. And some of the learning there has been clearly that, again, when you're working with that kind of a population, they need to be comfortable in the same way as we were talking earlier about marginalized communities. So that means that you need to be engaging through platforms, through mechanisms where young people recognize that there is a certain comfort level. So of course, over the last many years, online, social media platforms where digitally people are interacting with each other is something which has gained more and more currency, and this perhaps, every generation there is more and more comfort in working with that. So a lot of our work has involved hence working through online spaces, creating online platforms, creating catalogs, databases, museums where people can look at examples of lived experiences of other young people like them. We also do a lot of work on peer networking, peer leadership, peer counseling, so that young people are able to respond to the mental health needs of other young people. It's more likely when they see or hear from someone who is within that same age group as them, that they would perhaps feel a larger comfort, and also using mechanisms or tools which they are more comfortable with. So that's where the role of technology becomes important. And I think they have legitimate questions. They are also going through challenges. In fact, if you look at mental health specifically, India, for example, has among the highest suicide rates among adults and girls and young women. That's because there's a lot of pressures. There are family pressures, there could be relationship pressures, there could be education issues, there could be finance related issues, and all of that could coalesce on putting a lot of pressure on them. And to respond to that, of course, you need to recognize that these stressors exist, and then figure out mechanisms where you try to reduce the stressors, but also help them better manage the stressors.
Now, let me just, I noticed that when I was sort of saying young adolescents and young people, then at one point I said young men and women. And I said to myself, no, but that's not, because, what about the non-binary groups, right? And that reminds me that after sort of, I looked at your work, I asked myself this question about why WHO guidance actually is silent on transgender individuals with regard to HPV vaccination. Right. And that just is an example of how we just are not conscious of this non-binary identity, and in some cases where these groups really are high-risk groups, even then they are not reflected in technical guidance. So for all of us to just sort of look at that more carefully now going forward. So let me just ask you another question about trust, right? When we are looking at vaccine acceptance and demand issues, all of us have been emphasizing this whole aspect of trust or lack of trust, right? And which leads to then inadequate vaccination rates. And in your work, right, that you did in collaboration with Sabin, you have also highlighted that, that a lot of people now during COVID-19 vaccination articulated that their mistrust, of the government, of the public health institutions, of the pharma industry, and several other actors and institutions. So what do you think are some of the ways, to start building trust with communities that seems to have been eroded?
Sure. Yeah, no, absolutely. Trust is a major issue which has come up in our research, and I think was very well articulated in the conference as well by multiple other groups. And I think at the heart of trust is a few things. One is, of course, the kind of information which is available, which could also include misinformation, where it is coming from, and whether they are imbibing it in a way because it's coming from a place where they have a more belief, a stronger belief that this information is likely going to be true. The second thing is their own longer term experiences of interacting, whether that be with the government, with the health system, with the fact that they have not been able to get, let's say, affirmative care, accessible care. So they come from a place where they feel that we have never been thought of, we've never been responded to from our needs perspective. And now if something is coming and they want us to take it, then it's good for us to be skeptical, because we don't know what the agenda is, who's driving this, why is it that we are being reached out to when we are not usually spoken to, when our needs are not taken care of. And hence, trust has to be seen as a larger and a longer exercise. Building trust takes a lot of time. And that is true of any interaction, right? Whether that be a doctor patient relationship, whether that be an institution working with the community. Trust is an iterative process. It requires you to spend a lot of time building it, but trust can be broken very easily on the other side. So you need to also be careful about how you are phrasing your interaction with the communities. So a lot of times communities have spoken about the fact that why we have mistrust is because we've had all of these older experiences where our communities have not been taken care of, where our legitimate health needs, our valid health needs have not been responded to. When we try to access, for example, government services, we are not provided the services in a way which is respectful. Because for anyone, for you and me as well, if we walk into an institution and we don't feel that we are respected, it's less likely we would like to go back. So maybe we'll go back to the neighborhood quack who at least speaks to you nicely. They might be giving you a steroid shot for all that matters. But you would be okay with that because you don't want to be insulted. You do not want to be negated. You do not want someone to be speaking down to you. You do not want someone making fun of you. You do not want to go to someone who does not even know a difference between someone, does not know who a non-binary person is, does not understand how your name should be there on their case entry sheet. Things like these are important to communities because they could be triggering, they could make people feel uncomfortable. So I think trust building is a longer term exercise, and when we have these touch points because of COVID or because of a newer vaccine which is coming through, if we are starting to see pushback, then we should recognize that there might be something which is larger behind this. And before we label anyone, for example, as being hesitant, or that this is a community which doesn't want, or there are members of the community who are opposing for no good reason, we should step back and think about why is it that they are not taking this up. Do we need to have open, honest conversations? How do we have those conversations in a way that we are able to learn from this and then design our response so that they also recognize that this is important? And most communities over time did recognize that COVID was a major risk and we needed vaccines, but were just not initially very welcoming because of the skepticism that.
Or those who were okay taking primary series may be reluctant to take a booster,
True.
right?
True.
So I think so as you rightly said, this is not a one-time thing, but it's an ongoing thing. And really providing people with good information, timely information, authentic information is extremely important. So this brings me to my last question, Dr. Bhan, and that is about human-centered design. You have worked a lot on this whole idea of human-centered design. Here at the conference, all of us are talking about the need to have human-centered design. So what do you think are some simple ways of making sure that our service delivery approaches really sort of take this important dimension into account?
So I think human-centered design fundamentally is not very complicated in the way we need to approach it. If we think of it, if communities and individuals we want to work with are at the heart of our design approaches, the way we look at providing services, the way we ensure that we want to launch new programs, the way we want to run those programs, the way we want to ensure that individuals who are the front end of those programs, who are going to be in touch with communities, making choices around who those individuals should be, how we have open feedback mechanisms so that if there are concerns, those are heard but also responded to, and ensuring that this is happening in a space where it's not just the 5 programs which are funded, let's say, by an external player, which are the only ones being delivered, but a more comprehensive health system response which looks at all aspects of their life. When we say life cycle approach, it has to really cater to all aspects of their health needs. And of course also then working with other departments as required. But fundamentally, if we take that approach of centering communities, then we are taking a human-centered design approach. And that also then means that all of us need to learn what that would entail so that, it's not at the fag end of the creation of a program that we say, okay, let's do one community outreach program and tell them that how great this new vaccine is and you should all take it. But try to understand what would be the best way. Is it a mobile outreach clinic? Is it actually having a health center in the community? Is it having frontline health workers who really know the community, who are from the community, who are actually helping us deliver it, and also involving them in all aspects of decision making? So I think it's great that we are having more and more human-centered design discussions. There is a lot to learn from south to south. I think a lot of innovation which is happening in other countries could be of relevance to other countries in the global south. In fact, low resource areas in the global north as well, inner city Manhattan, parts of Baltimore, Geneva as well.
Yeah, so inequities are everywhere.
Right.
There is no part of the world where you don't see stark inequities. somewhere more, somewhere less. But I think really, as you rightly said, demystifying this whole concept of human-centered design and making sure you put communities at the heart of whatever we are trying to do. So thank you so much, Dr. Bhan. I'm sure our viewers benefited a great deal from your wisdom and insights. And to my viewers, thank you for joining us, and watch this space. We'll come back with another episode very soon. Thank you.